ETCTN 1043 is a phase 1b trial combining Erdafitinib and enfortumab in patients who have progressed on prior chemo and immune checkpoint inhibitors and have FGFR alterations, primarily 3. So the concept happened 2 years ago when EV was initially approved post-chemo and post-IO and showed a response of around 40% with the median PFS of 6 months and OS of around 12 months. And the same time frame, Erdafitinib, which is a pan-FGFR inhibitor, was approved for patients who have post-chemo, post-IO, and also showed a response of around 45.6% with improvement in overall survival. So clinically, we had this challenging conundrum where you have these two potential drugs, but how to sequence them. If a patient have received chemo and IO, would you give EV first or would you give Erda first if you have FGFR alteration? And that led to, this clinical question actually led to the concept initiation for the trial. Can we combine these the two drugs together and see if they have a potential synergistic or additive activity? And then patients don't have to go sequentially. We can give them as a combination because as you have seen in the past that when the patients go from one treatment to other, their performance status declines and it becomes challenging for them to go on a second line or third line or fourth line treatment. So that's where the idea stemmed. And then when you go on the preclinical data that was available that time, it showed that if you do a FGFR targeted therapy with chemo, they have some synergistic activity, which was seen in like endometrial carcinoma preclinical, as well as there was a trial done with docetaxel and vofatumab, which is again an FGFR3 and ADC, showed that the combination could be synergistic. So that preclinical and clinical data led to the concept initiation, which led to NCI and CTEP, and we started the trial. And if you recently see, there's also more preclinical data now being generated with Erdafitinib and EV, where it's showing that if you inhibit the FGFR, it actually upregulates the Nectin-4 expression. So that again correlates with what we are seeing clinically in our studies. Primarily, the goal of the trial was to look at the safety of the combination because it has never been done before. This is the first in human trial. So we wanted to make sure that even though they don't have any non-overlapping toxicity, we want to make sure that with the combination, it should not over-exacerbate the toxicities of individual drugs. So that was the main concept, and the main primary endpoint is to look at the safety and then also to look at the maximum tolerable dose and then the recommended phase 2 dose that we can take from this phase 1b and then move toward a phase 2 and then possibly a larger trial. What I'm presenting today is the dose escalation. So we have already done the dose escalation. We have the safety data and we have the recommended phase 2 dose. And right now we are enrolling in the dose expansion cohort, which is currently ongoing. In terms of the safety, if you look at the EV, you have the skin rash, which can be as severe and causing skin toxicity, such as Stevens-Johnson syndrome. Then you have the neuropathy. So those are along with hypoglycemia and eye toxicity. And then when you look at the Erdafitinib, you have hand-foot syndrome, diarrhea, hyperphosphatemia, nail changes, along with the retinal toxicity. So there are some predetermined issues that both of these drugs have. And that's where we are very cognizant about if there is any overlapping issue, then we can pick it up early on. So yeah, so that was the good thing is that if you look at all the data of this individual drug, there's nothing that says that this could over-exacerbate. So in terms of the skin toxicity, if you look with Erda, it's more of a dry skin issue as compared to with EV, it's more of a pruritic rash. So again, non-overlapping toxicities make it a little bit more feasible to try. In this dose escalation, we have 9 patients which are enrolled. We enrolled first 3 patients. We had one dose-limiting toxicity, which is grade 3 skin rash due to EV, which led to 3 more patients. So we have on the first dose level, which was Erda at 8 and EV at 1 milligram per kilogram. We enrolled 6 patients, and then subsequently there was no DLT, so we went on the second dose level, which is Erda at 8 and EV at 1.25 milligram per kilogram. And there was, since no DLT, we have chosen that dose as a recommended phase 2 dose. Of these 9 patients, as I mentioned earlier, everyone had a response. Two are unconfirmed because of the toxicity. They came off the trial. So subsequently, they progressed. But we have 7 confirmed responses out of 9. But overall, the best objective response rate is 100%. Over the 2.5 years of follow-up, we have seen that the median PFS is around 10.2 months, and the median overall survival is 26.3 months. The dose escalation is still ongoing. We have also the PK data, where we have the free MMAE and free Erdafitinib levels, and we have seen that there is no interaction. So that's the thing which can help us to understand that the drugs are not interacting with each other, and that's potentially also not contributing to overt toxicity in this patient population. And then in terms of the other aspects, we have seen that there are some patients who have completed 2 years of treatment and have come off. There are a few other patients who are still on treatment and doing well. The good thing about this trial is that of the 9 patients that we enrolled in the dose escalation, we have a 100% response. So every patient responded nicely. So we don't have a non-responder to compare with to look at the biomarkers of response or resistance. But what we have been doing is we are collecting ctDNA at the baseline, and then we are also looking at the ctDNA at the time of progression. So hopefully that will help us to understand if there are new alterations which are coming in the FGFR pathway that could tell us if there's resistance. The other thing that we will be looking at is we have some blood collected in different time points to help us to see if there's a clonal heterogeneity that evolves that could also point us towards the resistance pathway. So there are some biomarker work which will happen. Again, this is a small trial, so we will not have that much of data to generate, but whatever data that we generate could lead to a possible hypothesis in future that can be validated in a future trial.